thank you. This is a group of disorders for which there have not been many pharmaceutical treatments, so they have probably not come as much to your attention. It's been primarily an area where the therapeutics have depended on devices or surgical procedures or things like sacral nerve stimulation. However, it's a very important area of research. The key functional anal disorders are fecal incontinence, which has prevalence of 8 to 9% in the population and occasions a lot of impact on quality of life. There's an expanding interest in this both from device manufacturers, some pharmaceutical companies, and from the NIDDK. It's thought to represent an underdiagnosed, underrepresented group. Another of these disorders is Proctalgia, chronic Proctalgia. These are disorders which affect about 6% of the population. They are very challenging to treat clinically. There's some new data on their treatment that the committee has summarized very ably. And the third category is disordered defecation or dyssynergic defecation. This is again not something that's typically treated with drugs, but there have been major developments in the management of this category of disorders, which account for about perhaps 30% of the patients who consult gastroenterologists for the treatment of constipation. So the members of this committee are very well known to many people in the area. They include Adil Baruka from the Mayo Clinic, who's chairing, along with Satish Rao, who's co-chairing. And the other members are Dr. Felt Bursma, Giuseppe Sharioni, a colleague of mine from Italy, Charles Knowles, who's a surgeon, Alison Malcolm, who is from Australia and who does a lot of biofeedback and behavioral interventions for these disorders, and Arnold Wald, who has been one of the leading investigators in this area. The functional anorectal disorders are summarized here in terms of the diagnostic categories. I've touched on them already. So the key ones are fecal incontinence, levator ani syndrome, and the other proctalgias, and then constipation. The definition issues have there have been relatively minor changes in the criteria. One of the things that has changed is a change in the way fecal incontinence is dealt with by the diagnostic criteria. In the previous versions of the Rome criteria, fecal incontinence was separated into functional fecal incontinence versus organic causes of fecal incontinence. I think there's been a recognition that that distinction is artificial because most patients with fecal incontinence have some combination of causes like diarrhea as an exacerbating factor and sphincter dysfunction from things like obstetric injury. And so the distinction is often artificial since patients often have multiple etiologies. The Criterion Committee have decided to do away with this distinction and to drop the term functional from the definition of fecal incontinence. The functional anorectal disorders have traditionally been defined in terms of a distinction between disorders of function and disorders of anorganic or structural disorders. I've just mentioned this in the case of fecal incontinence. The committee is moving away from that and focusing on just defining the disorders in terms of the defining characteristics. There have been some minor changes in the way fecal incontinence is defined by the committee. It was formerly defined in terms of 2 or more recurring episodes of fecal incontinence occurring within the past 3 months. The committee felt that this time frame was inappropriate because there are patients who have had fecal incontinence episodes further in the past than 3 months. They may have been waiting for some time to receive a clinic appointment, and these patients would need to still be diagnosed with fecal incontinence. They felt that for clinical purposes, the diagnosis should be made if patients have had leakage of solid or liquid stool within the past last year, and that for clinical trials there should be a higher frequency of events required so that there's not a floor effect for the trials. They also point out that the definition of fecal incontinence doesn't include the leakage of flatus alone or the occurrence of urgency without fecal incontinence. Chronic proctalgia, again, disorders of chronic rectal pain. There have been no changes in the diagnostic criteria in this area, so I will not go over this in much detail. There have been, however, some important new developments in therapeutic advances in the treatment of chronic proctalgia, and those will be summarized in the Functional Anorectal Working Team report. Functional defecation disorders, again, is an area in which their treatments have been primarily behavioral interventions. There have been some major developments since the last Rome criteria. These are summarized in the new Working Team report, but there have been no significant changes in the diagnostic criteria.